But, there's no harm in trying a diet, right? Like that's kind of like the thinking, right? But like, let's sort of think about that. Like, I think there are some really, concerning potential harms, which I think most mums aren't aware of.
Welcome to Influence to Death, your guide for navigating the wild world of wellness influencing.
Hi, and welcome to Influence to Death. My name is Victoria Lafont.
I'm Hannah Wright, and today we have Dawn Whitten as our guest on the podcast. I'm so excited to have you here, Dawn.
Oh, thank you. Excited to be here.
Yeah, so Dawn is specifically going to talk about maternal exclusion diets. And there's some specificity around that, like in the context of eczema, or like if the baby has, some kind of like, if their stomach is unsettled, like if there's issues in the infant. But I also just am thinking, like, as we get to talking, there might be other aspects that come up, but I want to respect your, where you want to focus. But that'll be the overarching theme of what we talk to you about today. And
that's great.
As with most guests, we're not going to read Dawn's bio. People are like decidedly anti-bio, but we're going to link to all of her work in the show notes, and we highly recommend following those links. I would say whether or not you're a mom. I am not a mom, and I have gotten great benefit from looking at your work. So it's applicable to, I would say, people and females specifically, and then females even more specifically. So Dawn, do you want to start and just tell us kind of like how you got to the work that you're focused on? Give us kind of your backstory.
Sure. So I actually was kind of had a unique beginning in that I grew up in a household where my stepmother was a home birth midwife, and I was kind of surrounded by natural birth stories, lots of breastfeeding, and was present for a number of my siblings' births. And so that was just kind of my normal, which I guess would have previously been all of our normal time, but I didn't really realize that was such a unique experience, because that was, just what I was bathed in. And so actually I ended up, interestingly, having an early, I became a mum quite young in life. I was only 18 when I was pregnant, and I had this very supported experience because of my family. And so I had this very, empowering birth experience and an easy breastfeeding experience because I had all of this support around me. So it was very normalized, and I'm in this bubble. Then I went to study naturopathy, and, that was a really exciting, fantastic experience. I got pregnant in my 4th year, and kind of got interested in, what we were learning, which was kind of not very informed around breastfeeding and birth as well a bit. I mean, my course was it was an extraordinarily fantastic course that we did at Southern Cross University in Lismore, New South Wales, Australia. It was like a very rigorous course, but that was just kind of an area, I guess, that I noticed, and that it was kind of incongruent to the kind of the values and experiences that I had developed, just through, being in that context, that bubble I'd been in. And when I was quite pregnant, I went to this Australian Breastfeeding Association breastfeeding kind of course, that just a workshop to kind of prepare for mums. And it just kind of hit me of like, wow, there's so many barriers and challenges here, and I've actually come through life without having these because of my context. I mean, you can have you can have a context like mine and still have barriers because of physiological things going on or whatever, but it makes an enormous difference having that social and cultural context not blocking you. So that, I guess, just made me really, passionate about trying to kind of cross-pollinate that into naturopathic medicine, to just try and, this should be part of us. We're naturopaths. We're into nature and normal biology. You know, that's part of what we're about. So we need this piece. And I guess because basically, you know, breastfeeding has been massively impacted by, you know, the formula industry and I guess the cultural values of the Western world through that sort of, you know, late 60s to the, you know, till now we're still dealing with that. It affects every health profession because it affects every person that kind of brings their context to their profession. And, you know, there just hasn't, until, you know, probably the last sort of decade, there hasn't been a conscientious movement to try and correct that. But now there is, you know, there's so many people working hard on this, but I guess it's just one of the many people trying to do something about that massive kind of gap, I guess. Yeah.
Mm-hmm. Yeah, and you do it in a way that is like very specific and informed, I would say.
No, thank you. Try and be self-reflective, and, you know, I guess that's I think something important for us, and adapt and to change my practice, and that really comes into this topic that we're going to talk about, I think, because that's an example where I had to really pivot and change and learn from the evidence and think more deeply about things. Yeah.
Hannah, were you able to breastfeed pretty easily?
Well, yes. So that's a complex answer because I ended up having to have a C-section, unplanned. I did like I wanted to have a natural birth. And I was in labor for 24 hours. And then they were like, we have to do a C-section. Anyways, because of that, it took a while for me to be able to breastfeed. It wasn't like I thought it was supposed to be immediately after birth. And then there were some other complications. So it took about at least a week for me to actually be able to feed him like as much as he needed. So he had to have formula for a week, which I was just distraught about. But also I was like, well, it is what it is as long as he's healthy, you know? And of course, I'm like the whole time thinking from the C-section and the immediate formula, like his gut microbiome. And I was just like, you know, trying not to like panic about it.
Yeah.
But eventually I did exclusive breastfeeding, you know, until he started solids, and then continued to nurse until he was about 3.5.
Fantastic.
So for a long time. And I did have a hard time because I had dysphoric milk ejection reflex, which is the acronym DMER. It's very rare. Do you know about that, Dawn? I didn't know about it until it started happening.
I think that's the case for most mums that experience this. Like they're like, oh, this is a thing, and like other people experience this. Obviously, it's not common, but it's pretty difficult, huh?
Nobody warns you because it's so uncommon. You know, it's just rare. So that made it challenging, but I just like persisted once I knew what it was. And once it was about 1.5 years in, it started to affect me a lot less. I don't know if it actually improved or I just got used to handling it. But basically it's a hormone shift for some moms that happens, and it happens so intensely. It has to do with your dopamine decreasing like very quickly. And it makes you feel just really uncomfortable. There's like women describe it in different ways. Like it affects every woman a little differently. But for me, it was like this overwhelming feeling of almost like a homesick feeling, like just intense sadness and like despair, kind of like a sinking. And it was just out of nowhere. Like, and you would just have to kind of wait for it to pass, and after a couple minutes it would go away. But I think for some women it's so intense that they stop breastfeeding because of it and don't know what to do. They're just like, breastfeeding makes me feel horrible. Why would I can't do this anymore? And especially I'm thinking if you had postpartum anxiety or depression, it would be awful. So sorry to
say it again, Hannah. What's the name of it?
Dysphoric milk ejection reflex, I think. DMER. DMER. And it has to do with like your breastfeeding hormones, like
the oxytocin, how your brain responds to the oxytocin, kind of.
Wow.
Really, most people like, and I guess what, you know, evolutionary perspective is meant to happen in response to that hormone is like this, this feeling of safety and love and connection, like kind of the opposite feeling. And it's almost like there's some kind of alteration in how that hormone message is read by the brain. And it does, I don't remember the mechanism with dopamine, but it is, definitely linked with dopamine. And you kind of wonder what lays that down, that that disturbance there. And I mean, just hearing, we won't know, but just hearing your birth story, which was challenging, and I'm kind of imagining that there was probably some separation from your baby in that, and that all these things are, I guess, could potentially disrupt that feedback a little bit. Yeah.
I would love if someone could study that and see, because I did have a somewhat ended up being kind of traumatic. We were separated for 15 hours. It was very scary. And so I never thought that might be doing something and result in that. And I wonder if other moms with it had some kind of traumatic experience.
Yeah, I'd be curious to know what the studies are. I mean, I know that I've certainly had also patients who don't have an obvious trauma in their birth story, but I mean, I guess I would also see that as a suggestion that if you have another baby, it's not necessarily going to be the same, that you could have a different journey and a different experience. And that like lots of early skin to skin could help potentially to kind of reroute that reflex, that way that your body reads that hormone.
Right. Oh, that's so fascinating. How cool. Think about that.
Yeah. And Hannah, I know like you're saying like that actual issue is rare, but I will just say from like my friends that I talk to, I'm surprised by the large percentage of them that are like, they had some issue with breastfeeding that they just didn't expect. So like, Dawn, to your point, where it's like, I mean, naturopaths for sure, but like all, doctors are like birth providers. I'm sure they're so aware of it, but I'm, like I said, I don't have kids. I've just heard these stories. I'm like, I thought breastfeeding was like the baby, presses on your stomach to help the placenta. There's like all these beautiful like evolutionary like build-ins, and then they breastfeed, and it's like this, of course, but it's like
you don't have to think about it. Kind of
totally not the case for so many people. Their experiences is difficult.
That's right. And our health system is not geared around really providing adequate time and support. So I mean, like, I don't know, like having, usually there's a way of keeping mums and babies together, even if there has been, if there's some medical emergency going on, there's a way of doing that more than happens in countries like the US and Australia. We're terrible at it. Like, in Sweden, they're really aware of just trying to keep that couplet together as much as they can. Or, there's other ways of doing it where there's a lot more invested into that kind of early initiation period. Yeah.
It's so important, and it's hard to think about that. It's like we could be doing it better, and we're just not doing it better. And thinking about how that change would affect health outcomes, life for the kid and the mom, like how that just ripple effect, and then
so
the society.
Yeah.
Before we keep going, I just want to make two notes to the listeners. One, the little tweets that you hear in the background are the wild birds in Australia where Dawn is. I just want people to know we're not shutting the window. You're going to get to hear birds. So lucky you. And then the second thing I totally forgot at the beginning, and we've been forgetting, is to tell people how to get a hold of us. For probably like 10 episodes now, I think that we haven't given out that information. So if you do want to email us, you are more than welcome to email us. It's influencetodeath@gmail.com. On Substack, it's at influencepod. We're on Instagram at influencetodeath. So we're absolutely open to show suggestions or content feedback. Stay in touch with us. So I just want to put that in as an aside before we keep going. So, okay, let's talk about bias for just a second. So usually, it's like, that's your history. That's kind of how you got there, Dawn. And then I would just say, like, I have this bias when we're talking about the topic of exclusion diets or elimination diets, maternal or otherwise. Actually, before you like told us about this topic, I had never even really thought about the connection or the possible issues between exclusionary diets and moms. We'd always used it in our office as a way to like suss out, are there any type of food sensitivities or true allergies?
Mm-hmm.
But when you brought that up, like immediately in my mind, I was like, that's probably not a good idea. Totally uninformed. That's just like what popped up initially. So that's kind of the bias that I came in with. And over the past couple of days, just starting to look at the research literature, there's all kinds of information that I've come across. But just for people to know, like, that was my initial reaction to hearing about that. But I can also see where it might be very, very popular, especially when you're dealing with something as like elusive and quality of life affecting as eczema or any type of dermatitis.
Yeah. I guess in my mind, an elimination diet in a non-mom is like a different category for some reason than like a mom who's doing that, because to try to fix whatever's going on with her baby, even though it's basically the same thing. But I've just known so many moms who go through that. I mean, I don't know if it's just in my area where I live, but almost every single person except for us that I know with kids and babies has dealt with eczema, colic, digestive constipation, stuff like that in their babies or their toddlers, and has tried, if they were breastfeeding, like, well, I guess I'll just cut this out and cut this out, to see what it is. And I was always like, maybe that's a good idea. Like, make sure something you're eating isn't affecting your baby. And so I'm excited to learn more about it today. So I guess I don't really have a bias. I'm just like aware of how prevalent it is, really, because of the allergy response in like kids seems like really high. And maybe I'm just around it a lot because I'm a mom, and I'm friends with other parents, but yeah.
Yeah, Dawn, what is the story?
Yeah,
Take us to school.
Yeah. Do you want me to share my bias as well? I mean,
totally, sure.
Yeah. I mean, I feel like I kind of sort of feel like I'm a bit of a pendulum with this, where I'm reacting a little bit to the over prescription of elimination diet. So I guess one thing I'm conscious of is, just kind of still just trying to stay like open continuously to the possibility of, those not common instances, but those occasional instances when it is warranted. So I guess that's the thing I feel I need to make sure I'm staying in touch with, that I'm not, they're not throwing the baby out with the bathwater kind of thing, that you just like, just try and stay grounded in the middle. But yeah, I mean, allergy is like, it's extremely, extremely common. And I think, I don't think it's just the people that are going on these exclusion diets, the mothers, I don't think it's just them. It's just such a common presentation for me. And, if you just peruse on social media a little bit, there's a lot there. Yeah. And I feel like I just hear this phrase. I don't know why. I just hear this phrase from so many mums, I'm down to 5 foods. I'm only eating 5 foods. Like, I don't know, there's something, I just hear that over again. And you can imagine just eating 5 foods, it'll be like, I don't know, 5 foods will be often things like, chicken, cabbage, I don't know, swede, potato, and I don't know, one other thing. And you're like, how, like, that's miserable.
Yeah, it's miserable.
Yeah. And the same with elimination diets, you hear that too, but it's hard, like thinking about a breastfeeding mom and they can only eat that and they're already tired and they can't have the joy in their food. And my question, like, for people I've talked with, is like, is somebody helping you add foods back in, or are you just cutting that out for the foreseeable future? Like, and they're like, well, I'm kind of just cutting it out, and they're not really getting that continuing.
They're often seeking baseline. They're like, I'm going to keep going until I get baseline, so that there's this kind of looking for this point where there's no symptoms, and then start bringing back foods, which, I guess, like, if food is the cause, there's be some logic to that. But I think the reality with so many of these presentations, it's unlikely that that is the cause of what's going on. Or, it's a possibility. It's probably not the first place we should look for understanding what's happening with your baby, unless we've got some really good, evidence, and we're worried about their safety.
Right.
Then let's look at the other more likely areas to work on, and not not have you start there first. But I think that when your baby's suffering, you want to do something, and you feel like you should really do a lot, of course, and when you go and on the, you're like, how can I've got to be active in this. And that's a really, that's a natural and helpful way to feel. But I think it does drive it a bit, this thing of mothers feeling like they need to just, cut more, do something more. And I guess there's the social media support groups out there where there's sort of, this encouragement from other mothers that are also cutting out foods, that kind of everyone kind of gets spurred along potentially. And, there can be some people in that community where that actually has been important, but that just so easily gets generalized to all the other people there who are, just seeking, just desperately seeking to kind of get control of the situation with their infant. Yeah. So super.
Dawn, that's like the seed of almost every topic that we cover, which is there's a grain of truth, and it's really important, actually. It's crucial, but then it gets bastardized with all of this other stuff, and the other stuff is the influence. You get influenced to death. That's why we started the podcast, where it's where is the balance? Where is the truth? And how do we kind of help people navigate that when they have so many forms of influence, Facebook and Instagram and TikTok and everywhere telling them that okay, yeah, who do you listen to? So, okay, where would a mom maybe start? Where would be the best place to look first? For eczema,
for understanding what's happening with their baby. And maybe I can just sort of back up a step from that, if that's all right, to kind of think about, okay, what's potentially lost when you go on an exclusion diet? What do you pretend, because you feel, I don't think parents are aware of the risks of making that. And I think, you want to be making an informed decision about this. It's will this potentially give us a symptom control in this picture? Maybe, but maybe, quite likely it's not the cause. But, there's no harm in trying a diet, right? That's kind of the thinking, right? But let's have, let's sort of think about that. I think there are some really, concerning potential harms, which I think most mums aren't aware of. And if we just, start thinking about the baby, because I guess that's what's driving this, and not thinking about harms to mum, there's so much fascinating research coming out, showing how important the immune programming that happens through breast milk is for helping to prevent allergies. So this is really, really interesting how, those food proteins coming through in mum's milk actually play a really important role in helping to teach that baby to become tolerant to those proteins. And they come along, the protein comes along in a very, very low dose form, so low dose that most people that had a confirmed IgE allergy could drink that milk without having any reaction. There's such a low exposure. There will be, they suggest that it's probably, potentially 1 in 1,000 or less than 1 in 1,000 people with an IgE confirmed allergy might have a allergic reaction to the trace amount that's in milk. So it's generally, for most that people, a very low exposure when you're thinking about an IgE reaction, which is one type of immune action.
Let's clarify that for listeners real quick, because I feel like my brain is going to explode.
Sorry,
I just want to make sure
you're trying to pack too much in.
No. This is amazing. No, it's not too much at all. I just want to make sure people understand an IgE is a true if it's not yet, can lead to anaphylactic or syncope. My husband has IgE allergies and he just passes out. He's like a fainting goat. We joke. So, but it's it can kill you. And so what you're saying is, in breast milk, the levels of those proteins are so diluted that somebody who has a shellfish or peanut allergy would be able to ingest that, and they're fine.
Yeah, as far as that's that's, you know, I guess that's where the research is at. I mean, it's worth noting that if you eat shellfish, you probably end up with some on your hands, and then if you then like hold your baby, or you know, hold your husband, like then they or partner, then yeah, they could be more likely to react to the trace exposure that's on your body, you know, that's on your hands from preparing the food. So it's still really important that we're really, really careful if an infant does have confirmed or suspected serious IgE allergy. I'm not saying just go and eat that food but I guess just to kind of give some reassurance around the level of exposure that's in milk. It's really low, and it's not always there. You can eat a food and it will come through one time and not the other, because there's other factors involved in whether that protein actually makes it into the milk. Lost my train of thought.
I'm sorry.
No, that's all good. I think
tolerance
was
it.
Yeah, so this is this important tolerance mechanism, so that you know, that exposure is really important for laying down that tolerance learning. And if you've got an infant with eczema, that's even more important. That's really you really want to do everything you can for that infant to not, you know, grow into having other, you know, to having food allergies and airborne allergies. So knowing that actually that trace exposure that you could be offering through your milk could be helping to kind of provide a tolerance opportunity to that infant. There's really interesting research on peanuts, and this is not in a population with eczema, but what they found is when mums ate peanuts through lactation and they gave peanuts early, so kind of from 6 months onwards, and gave it before 10 months was the kind of the golden kind of message, that resulted in the lowest level of peanut sensitization. When mums excluded peanuts and then they just gave the peanuts to infants as an early introduction, the rate of sensitization was so much higher. So this combination of that early exposure through lactation and then bringing that food in early seems to be the winning combination for really, you know, promoting tolerance. So I guess excluding a food could be having that impact. And another impact to that infant is the loss of flavor learning. So when mothers are eating a really beautiful, diverse diet, or that infant's getting exposed to all those flavors in milk, and there's clear research to show when there's a restricted diet that affects you know, food preferences and can lead to like picky eating. And you can kind of just imagine the flow-on effects to overall health if you set up. And you know, like we all know that, you know, 2-year-olds will go through picky food. You know, it's a natural developmental thing. So you know, don't be like, oh no, I didn't eat diverse enough. Breastfeeding. But yeah, I guess just kind of sort of just thinking about the potential costs to the infant, and then we think about the broader costs of, you know, the nutritional impact to mum, and you know, there's a lot of resilience in breastfeeding, that even when you're quite restricted in your diet, as long as you're taking care of key nutrients, the milk nutrition will still be excellent. But you know, over a period of time, if you keep going down there, then I guess we can see some potential impacts flowing onto infant health too. We know that mother's microbiome would be affected by these kind of restrictive diets, of course, and then the stress of following that diet is, you know, is substantial, and the financial cost to families. And this often, you know, leads mothers to start thinking about weaning, and often they'll be starting to be given advice from health professionals. You know, this looks very hard what you're doing. Why don't you just put your baby on a hypoallergenic formula, without us even really kind of unpacking, like, does this exclusion diet actually make sense in the first place? But yeah, so that then we have a really big loss to the mother and infant if that's the path that ends up being chosen. So yeah, that's kind of like a backstory that I think about.
Those are the risks. I mean,
of an diet for a breastfeeding mom.
Yeah.
How many questions do you have, Hannah?
What's that? Sorry?
I said, how many questions do you have, Hannah? Because I have like 15,000 questions that I want to ask.
That's so fascinating. I mean, the part about the allergy with become tolerance through breast milk is so important, because that's such a big concern for parents, is introducing solids and introducing the top allergens and being so afraid that their baby will have a reaction. Like I think they tell you to, I bought a bottle of like children's Benadryl just to have on hand just in case, although like you're not even supposed to give it to an infant, like, but I was like, maybe just in case I'll have this.
Yeah.
When I introduced like peanut butter and wheat and stuff like that. That's really fascinating. And those guidelines have changed for the oral introduction for babies. Like for a long time, it was like wait longer, and then now it's shifted. Like you said, before 10 months seems to be like a greater benefit for preventing food allergy.
Yeah.
So yeah, that's really important information.
Yeah. And I think this is an interesting kind of nuance point, actually, because we have an industry player influencing this conversation, and that's the baby food industry, that really does love infants to start solids earlier and earlier, because then you can sell puree, because you can't really sell puree to after 6 months. Infants are like, I don't want that mush, like, get that away. So they've got to get into that market. So they do love leveraging off any message around bringing solids in earlier, but like there's really consistent, clear evidence and guidelines from all the major health bodies that exclusive breastfeeding should continue. The recommendation should continue to be till around 6 months, but then we look at bringing in those food allergens early as they start solids. Have them. Maybe they're not the first foods that come in, but they're coming in early in that sequence, and and we're trying to get being aware of kind of getting through all of them before 10 months and keeping them regularly in the diet.
Sorry, can I just ask Dawn a question really quick? So you said with the early introduction, and that is really, I see moms doing that, especially not just because of I think definitely the baby food industry, also pediatricians will say, go ahead and start. Like my pediatrician was like, 4 months. He's like really well developed. He's super healthy. He's big. Like, why don't you? And he didn't sleep through the night, which is normal at that time. But they're like, you start giving them, these foods before bed. And I was like, his digestive tract isn't even developed yet. Correct? Is that right, Dawn? Is that why 6 months is the time when their GI tract is more developed to handle food?
Yeah, that's one part of it. And then also, I guess, once we bring in solids, we're starting to dilute the protective effects of breastfeeding. So infants are more likely to get respiratory infections, gastrointestinal infections. And so we want them to be that just, ready, like a bit more of time for immune development. But increased risk of obesity and other, health consequences as well with the earlier introduction. And then from a microbiome perspective, we've got this period of time when you've got exclusive breastfeeding in the picture is like a really important immune programming time, and that's the time when you've got this typically a really high dominance of bifidobacteria just doing this incredible work programming for tolerance, but also effects on cognitive development. So there's that. Once we start bringing in solids, we just start seeing the ecosystem starting to shift, which is normal, but you want to have an adequate time in that kind of key infant specific ecosystem period, not sort of shortchange it. That's I guess another reason. But I think that it's very clear, but it's just that trickiness with like those baby food industry lobbyists. They've just been they've been at play for a long time, and so and they have a lot of influence, and so they can just kind of get involved and sort of distort the message a bit, and health professionals won't even realise that they are not necessarily following the guidelines in their recommendations, because this almost sounds like a guideline.
Yeah,
actually, what the guideline is not before 4 months. Around 6 months, not before 4 months, because that was kind of argument about the wording, but because they're like, okay, we definitely don't want people bringing these things in before 4 months. No, but somehow it's sort of and there are researchers looking at bringing in these food allergens before 6 months, but it's just not. The evidence is of that being more helpful is just not clear. And then we're also throwing out these other health benefits that I've received from that adequate period of exclusive breastfeeding.
And when you look at like traditional societies and breastfeeding traditions, like what do you think the common ages were to introduce food? Like,
yeah, I think it's like difficult to get clear information on because there's so many. I think it's not been easy to figure that out. And I guess there's the whole the agricultural period where like how humans have evolved, and then we had that settling down agricultural period. And I think potentially some errors were made during then when they started being, we can feed this to babies. And then I think there's maybe archaeological, this is like going back foggy in my brain, but archaeological evidence that they could see impact to infant nutrition at that time when humans settled down and stopped being nomadic. So yeah. But I think we never had until then we didn't really have purees. There was hand to mouth feeding where mums would chew and give so possibly it was happening a little bit earlier, but it would have been pretty small and it would be very much directed by the infant, and you were going to do what was easy, breastfeeding and not having to carry food around with you for an infant is easy when you're in a nomadic situation.
Even in a modern lifestyle,
it totally is.
And then once you start worrying about planning snacks and having food on you're like, oh my gosh, can I just breastfeed you?
Exactly. And the extra cleanup and you just don't realize until you open that gate, do you? When you start. Yeah.
I wonder if it would be useful to our listeners, and I don't know the answer to this, to talk a little bit about tolerance. I know in adults the tolerance mechanism, but I think people hear that word and they're maybe not exactly clear what is meant by tolerance as far as our immunity goes. And then you also talked about kind of I would call it the microbiome immunity crosstalk or connection. Does tolerance work the same in babies as it does in adults?
I think it's a unique time in infancy because you're just meeting, all the proteins in the world. So you've come. Obviously you must typically be exposed to proteins in utero, but it's bam, which things are friend, which things are foe, and that is the role of the bifidobacteria, is to help train the cells in the gut into be this is friend, this is foe. That's kind of a very simplistic way of describing that. But yeah, that's our understanding that microbes are involved in that. And then all the incredible messages coming through mum's milk, so many immune programming messages coming through mum's milk so that baby can learn, which things are friend, that these proteins are a friend and I don't need to react. I don't need to have a reaction to this. And then this is possibly a pathogen, so I should mount a response to this kind of thing. Yeah.
Which is also, I don't want to say that it's good when babies get sick or when kids get sick, but again, I have very limited knowledge of this. From what I've learned, it's it's not bad. It's you want kids to have appropriate immune responses, and sometimes that means getting sick or having a response that they don't feel good.
Yeah, it's normal to have that. And I guess we think of the breastfeeding infant as having a hybrid immune system. So it's almost like part of their immune system is in their mother. So when mother's exposed to the pathogens that are in the household, they'll actually make antibodies specific to those pathogens, and they'll come through in the milk along with a whole bunch of non-specific immune protecting effects. And then we've got an ecosystem that helps to reduce inflammation in the system. So we're kind of providing a protection so that when that infant gets sick, they can have a more milder experience, and they've got that immune that immune branch that's in their mother that's helping them fight it, because they haven't actually, their immune system's immature and they don't quite have everything that's needed on their own yet. And then also just to help to make sure that inflammation isn't kind of there's not impacting their system as much. So the inflammation is kept a bit more in check. There was another point I was going to make about that. No, I can't remember. But yeah.
I feel like it might be worthwhile to come back to this at the end once, like we've talked about the risk of exclusion diets and breastfeeding, the like connection.
Maternal exclusion diets and breastfeeding, yeah.
Yeah, but maybe at the end, after we talk about more of the places to look to address eczema versus exclusion, we talk about like what happens if, someone can't breastfeed, like what would be good
to help their baby like develop and that immune system. Yeah.
Sure.
I just don't want to forget about that.
Yeah, we're putting a little like tag on that we're coming back.
Yeah, totally.
Right. Yeah, it's a big topic, isn't it? Everything kind of runs into other bigger topics. But yeah, okay, so we've got an infant with eczema. Is this what we're thinking about? And what, okay, what else could we be thinking about in this infant in terms of what we look after, like, as when we're trying to like address it and where we could go before thinking about elimination diets. And I guess eczema is so common. It's just like it's ridiculously common. I should have looked up the stat before we started, but I think it's like a third potentially of infants will have some form of eczema in their in that sort of 0 to 4 year old.
You're right. That's exactly right. 30%. It's what the NIH.
So it's a lot, and that's really, really common. And when we look at the things that predispose to eczema, that I guess that there's a whole like world of things that we could explore with that. But I guess we're really learning how important the skin barrier function is in driving that condition. So instead of I guess thinking like, I guess we can sort of go, the skin barrier, it's like superficial, like we should treat inside, but like the skin barrier is our interface to the environment. It's like an organ, like it's not superficial. It's like, and I guess along with that, with the skin barrier, there's also sort of thought about, the barriers of the body when like I guess when there's a disturbance there, that can be, a real driver for either immune dysregulation, whether that be allergy or autoimmune disease. And that this modern world that we live in is full of things that disrupt those barriers. So you may have heard of the epithelial barrier theory, which is this idea that things that disturb these barriers are driving a lot of disease. So we've got that in this picture, that we've got babies are actually born with immature skin barrier, so their skin barrier function's already it's immature, so it's already sensitive and vulnerable. And then we've got a lot of exposures that can disrupt that barrier further. And then there can be a genetic component where there's that's actually quite common to have a genetic element where you just affects your skin barrier structure. And so I guess for some, if you're just immature like a baby and you have this genetic issue and there's nothing else at play, like maybe you would have some mild eczema that you would hopefully grow out of. But I guess if you add these other layers on of these other sort of disturbing factors, or the pollution and the lack of, I guess we could say just broadly, there's like too much bad and not enough good, because there's also like a deficiency in exposure to things that are modifying and regulating, being in, wild natural environments that influence our skin microbiome and help to support more regulatory pathways in our skin. The absence of exposure to those sorts of environments, and then excess exposure to the pollutants and detergents, particularly soaps and all these things that are really disruptive for the skin barrier function. So that hasn't answered the question about how to treat it, but I think just understanding, some of the things that might be driving it is important. So, because then we're like, okay, that skin barrier is vulnerable, and what we're learning with allergy is the way that allergy, like one of the main routes that allergy might develop is through your body basically meeting the protein through the wrong door. So instead of first meeting that protein through the gut in your mother's milk. If you first meet that protein on your skin through a disturbed barrier, then your immune system can be like activated by that. Yeah.
Do you remember that blog, Hannah?
I was just trying to look up that paper, but I was trying to find the number of kids who have atopic dermatitis, eczema, skin barrier, whatever, their skin is irritated, who are exposed to lotions containing peanut oil, either baby oils or lotions, or like from their mom, like skin to skin contact. If she's using it, the increase in them developing peanut allergy, like the IgE serious allergy, is so much higher. And even when they're not eating, like you said, because they're introduced to their skin and their immune system is like, what the heck is this? Like attack, I mean, that's so fascinating and so critical to know too. Like if you're
absolutely
a baby or a toddler with eczema, to be really aware of what kind of stuff you're putting on their skin, especially if they haven't been consuming it. I guess if they had already been introduced through the GI tract, it would be okay. I can't remember. If I find the paper, I'll put it in there.
Absolutely. And I think there's been similar findings with some other. I think we know most about peanuts, I guess, because it's an allergy that's more kind of more common and serious and on our radar. But it comes up with things like coconut oil, oats, which is very interesting because oats have like wonderful skin healing action. Like that's a beautiful thing to use on eczema, but it's I think problematic doing it early on because we haven't developed that tolerance. And I guess in practice the way that I would approach it is I wouldn't be enough that mum was eating those foods and bub wasn't reacting to them. I'd want to wait until that baby tolerated them well in their diet before I thought about using any of those things topically on the skin. So, so I tend to just be really aware of what I'm using on baby's skin and make sure that there's no sort of common, certainly no common allergens and no foods that are, I guess, I tend to just try and reduce things that can be part of the diet. But I do use olive oil because olive oil, cool. I haven't yet met someone with an olive oil allergy, but look.
Oh, God, that would be horrible.
Wouldn't it? It'd be a terrible curse to have that. But I think, this is a really important thing for people to be aware of. And it's, just like being careful, reading the labels and,
Okay, so do babies need soap? Like, do you need to put soap on it?
Definitely not.
Okay, because when we lived in Hawaii, I remember God, this kid was probably close to 2 years old. And I remember we went to give him a bath and we had just Dr. Bronner's, I think baby Dr. Bronner's. His mom was that's the first time he's ever had soap on his body. I mean, we were pretty primal. We were living pretty close to but she had just rinsed him off and he was fine.
Absolutely. Well, this I think that's one of the key things around is just reducing exposure to anything that could be disruptive on the epithelial barrier, and soap and detergents are just right up there because not only are they stripping away all the natural waxes and things that your baby's making as a barrier, they also are alkalizing the skin, which is meant to be acidic, and by alkalizing the skin we're kind of helping Staph aureus to populate that skin, and Staph aureus is very linked in with we haven't talked about it much yet, but it's very linked in with atopic dermatitis. It's a real driver having that an overgrowth and overactivity of Staph aureus on the skin. And
and I mean, it's so, baby soaps and things are so heavily marketed, and you're like, oh, the bubbly bath and the baby, and he's gonna be all clean and smell good, and not thinking
pictures of them with all sudded up,
right? The studs and so cute, and we get this idea that you have to walk we're dirty or something. It's the baby's not dirty. The baby's not doing anything great. Like he's not out there like in the fields getting all sweaty. And even then he probably couldn't go without soap. You know?
Exactly. And water's a pretty good solvent for most things. So like if we've got a bit of dirt on them, then yeah.
Look, to be fair, like I don't think I've used soap on any parts other than my like crevices in years. I'll take an oil bath in the winter because I'm so dry. But I mean, so to my point, like, do babies need like? I definitely need soap on certain parts, but on other parts, I'm like, I don't think I need soap on those parts.
Yeah. Well, I totally agree. I'm on a campaign to reduce everyone's soap use because it's really disruptive. It's disruptive from the vaginal microbiome. It's just like you like increase your risk of UTIs.
Yeah, if you share like you don't use soap, I've gotten like really judged hard about that. They're like, oh, disgusting. Whatever.
You're in good company, Hannah.
Yeah, indeed. We'll be around to pass on the microbes that people have lost from using them.
So Dawn, would you say like when I think about the skin barrier, you're saying like soaps and detergents and
chlorine?
I live in Boston. Chlorine, okay.
So baby swim classes, like that's often a common time where eczema might turn up. So if you see that picture, with baby swim classes, if there's like an exacerbation or a turning up of eczema, I'll be like, okay, well that's the chlorine. But sometimes if it helps, which is weird, you'd be like, okay, I think we've got a Staph aureus overgrowth on the skin here, and so that's knocking it back. It's not necessarily good for the skin barrier, but you're seeing a temporary reduction in the, that it's sort of reducing.
It's like an unideal troubleshooting.
Yeah, exactly. It is unideal troubleshooting. But I think, like that's just a really important message. If the only thing people take home from our conversation is don't put soap on your baby. And also that first bath, when your baby's born, they're covered in this beautiful vernix that has this really like this kind of waxy, sticky, not sticky, but waxy layer. They're sort of like a white kind of smudgy stuff on them. We don't want to wash that off. Like that's got a really important role in protecting their skin. It's helping to influence the skin microbiome development, and so we want to keep that on. And ideally, we don't really want to bathe them in the hospital where they're going to pick up these problematic microbes on their skin. That's so if we can kind of cocoon them in our own sort of microbiome kind of sphere, and then wait until they're at home before they have that first bath. And so they're like, okay, wait a week, like ideally wait a week to have that first bath and no soap.
And moms can, or parents can make that request if you're having a hospital birth. Like that is totally within your right to say, I don't bathe my baby.
Yes.
Like for me, that was my plan, and then I was not aware of what was happening, and then I realized he had been bathed. And I think if I had I planned to do it in the moment, be like, let's not bathe them. So if you put that in your birth plan or whatever forms you give the hospital, and let the nurses know, please don't bathe them. They should. They should.
They weren't necessarily going to ask you, are they? How do you feel about us bathing your baby? Unfortunately,
I also feel like it's I can feel in me, I lived in such a. And you all have this. Obviously, we have some similar experience or way of thinking because we're having this conversation. But it's living in a way where this is normalized is so rare that I can just imagine people listening and being like, what? I'm not going to bathe my baby. So I just want to speak to that. There is a time of transition of starting to understand there are these forces that are actual it's our physiology that is human and non-human that we can nourish in a way that is the polar opposite of how we've been taught to live, of sanitation and only focus on germ theory, right? We had this conversation yesterday with our other guests. It's germ theory and environment, or I think I said this yesterday, Beauchamp and Pasteur, they both had great points. It's both of those things exist, but when you've lived in a culture your whole life where sanitation is the number one, goal, everything clean and that, this might feel really foreign. I just want to say that. It might feel strange to people, but there's a lot of wisdom here that I think has been lost, that we would be wise to regain.
Yeah.
Actually, over Thanksgiving, my hair is so short. My mother-in-law was like, "Oh, your hair is so shiny. Like, what shampoo do you use?" And I was like, I haven't washed my hair with soap in so long. And when it's short, when it's long, it's a little fine and it like looks oily, and I'll wash it every once in a while with, whatever organic shampoo, bougie thing I end up buying from Whole Foods. But when it's short, it's like I will get it wet and I'll like massage my scalp and put oils and like that, but I don't wash my hair. And she was just like, she wasn't judgmental. She was really lovely, but she was like, I never even thought that was an option.
Right.
Was that be possible? Like, shouldn't you like have like sort of like, I don't know, like some, I don't know, dirty like kind of scum on your head or something? Because
and meanwhile, my hair is so healthy. My scalp is super. I have like really healthy skin.
Yeah, and it's all in balance.
Yeah. So
yes. Well, we didn't kind of evolve with the bar of soap. Like that's a new thing.
Right. And so, okay, this is maybe a helpful question for people. If they're just like, okay, I can kind of get behind this to a point, but like, what kind of soap would be, if they're going to use it, like would tallow soap be good or anything? Olive oil soap? Or
I think we just have to like
rinse them off.
No soap. Like it's just Yeah. I think there's no good soap
on a baby. Like I mean, my son didn't have soap he still doesn't really get soap. Like for the most part.
He's so young.
We wash hands and stuff, but like, we're definitely unsanitary, quote unquote, because we just don't adhere to that kind of mainstream view. But for an adult, is there a soap preference? I bet listeners are wondering that.
Yeah, I mean, I'd probably say a Castile, like an olive oil based soap, but and just, I mean, I think really just hands. I mean, sure, if you want to do armpits, but like definitely not groin for a woman, because then you'll be affecting the ecosystem, your vaginal ecosystem. Even washing the anus with soap increases your risk of urinary tract infections. So like people feel that, I must clean, but like just water is a good solvent. And
Cool. I love that.
Oh, so
100% down. I mean, that's literally how we lived in Hawaii for years. We had a lemon tree, so we were so fortunate. We would just pick a lemon, and then we had those coconut scrubbers. Have you all ever seen those? So we would it made the skin feel so good. It would like warm you up, and we would just put like a little lemon in the places that would get stinky. I mean, we work outside all day on the land and then rinse off. And
beautiful.
It was great. I didn't have rosacea
and that's
there.
acidic too. That's so interesting, because I think like that's a really big issue, is the pH effect of when we use soap and detergents. But you'd be using lemon, which has been acidic. So
acidic,
interesting.
Okay, so the chlorine, detergents, soaps, genetic predisposition, is there anything else that people should maybe be aware of?
I mean, I guess thinking like when they're thinking about like treatment for their infant, I guess be thinking about supporting and healing that skin barrier health. So, and that might be thinking about microbiome health on the skin, and it might be thinking about, what sort of emollient support to put on the skin, and to really know that those are actually getting to the root cause, because you think you're doing something superficial when you're looking after those things, but this is actually, this is an epithelial barrier issue that's happening at the skin, and we need to feel like, we actually are addressing the presentation when we work on that level. And then I think we can also think about, nutritional elements that we can work through mothers. So we can think about, nutrients that are really important for immune regulation. So, that disturbance is happening from these external factors, but internal factors, of course, can affect the skin health and immune regulation at the skin as well. So think about, adequate vitamin D, so that there's a good amount of vitamin D coming through. We think about the omega-3 balance. We think about, that, how mum's, supporting mum's microbiome, so she's got more anti-inflammatory short-chain fatty acids potentially coming through, and, all those, we can work on those layers as well. I mean, I think that generally that's kind of the main kind of areas that I tend to work on when I'm working with infants, and then we, you know, when we kind of see how we go with that, and we also have this kind of, you know, we were talking about, you know, how important it is that exposure of the proteins through mum for developing tolerance, and we know that infants with eczema have a much higher risk of developing food allergy because of this, what you were talking about before, Hannah, with the, you know, that skin barrier being leaky basically, and we've got leaky skin, and then the exposure to the skin of food allergens, either with stuff that we're rubbing on, but just stuff in the environment, you know, it's just naturally going to be exposed to it. So important that for that population in particular, they've got this high risk already. So we need to be really thinking about that in terms of making sure that we're putting in place all the things that we can to help them be less likely to grow into food allergy. So I sort of feel like in that population, it's even more important that the mums are eating those food allergens regularly, and that, yeah, we've got that plan with the solids.
Oh man. Okay. I just want to say that is incredible, because it's kind of the opposite of what you hear in a lot of functional medicine I just advice, like including myself, and what I used to believe is that, like, you have eczema, it's your gut. Your baby has eczema, it's their gut. That's what you address first. And like, this is like, we'll address their skin barrier, and that's like primary, like start there. That's just, I'm just like, okay.
Yeah, I know. It's like,
put that
it's
in there.
superficial. What do you mean?
Well, I think anybody who's dealt, like I had severe rosacea, Dawn, and so anybody who's dealt with a skin barrier issue, intuitive, like when you're talking, I'm like, yep.
Skin is an organ. I feel it.
Sense to me. Yeah, absolutely. Okay, and so when you're saying that, like emollients, like, is there like a certain emollient that you like for babies?
Yeah, I mean, I love shea butter. I like for mild like eczema. I often find, you know, doing kind of the you know, the general kind of healthy lifestyle shifts that we talked about, and, you know, removing as many disturbances as we can, and shea butter as a moisturizer, that actually, you know, is enough in a lot of, you know, if we catch it early, and that can be enough. But the other thing I really like is a combination of shea butter and jojoba oil. That's a really nice combination. Jojoba oil's got beautiful waxes in it. Yeah, but it's so individual. Eczema is just such, or atopic dermatitis is just such an individual presentation in terms of what works for an individual. So you do need to kind of, it's hard because, as you know, parents often have to go through a lot of experimenting, and that can be kind of discouraging when you're trying different things. But yeah, I guess it's just like keep trying, and and don't, you know, that you find the thing that works right for your infant skin, and that can change. I also use quite a lot of so that's more just as the emollient. I mean, so often there is this microbiome disturbance at the skin that's really feeding into that picture. So I'll often do sort of botanical baths with green tea in them, and like other, you know, a couple of other herbs that I might use in them to help to just sort of help to suppress that Staph aureus a bit, and then. But we want to be careful about not over bathing as well. So there's this thing of like the nuance of that individual, you know, it'll work for some but not others. So it's really about, you know, just paying close attention to what works for that infant, which, I mean, I think, you know, parents are really good at that. They really tune into that and be like, oh, this cream you gave me, but that other one that you didn't think would work, actually that one works better, you know, like I usually go, okay, here's 3 creams.
As a clinician, that's such a clinician, it's like 100% what happens when you're in the office. Like, this is probably not going to be it. And they're like, that was perfect.
Yeah, that was it. That one you said was unlikely that you just did as a last minute sort of tack on. That's amazing. I'm like, okay.
Yeah. It's humbling to be a clinician.
Isn't it? Yeah, totally. Yeah. But I would often be thinking, okay, first we'd want to do like, just try emollients. You know, is that enough? You know, especially if it's mild. If it's more severe, we might be doing a kind of a targeted therapeutic cream, which has got, you know, healing agents in it and anti-inflammatory agents in it, and also like a bit of selective, Staph aureus suppression kind of action, and maybe some other anti-itch, as well, because that, scratching is something we didn't talk about as a skin barrier disruptor. It's enormously skin barrier disrupting, scratching, or little babies like learning to crawl and crawling along carpet, and then they just start to get, that a site that wasn't a problem suddenly becomes crazy problem because of that rubbing. So that the cream would be kind of have these therapeutic elements, and we'd put the cream on the kind of the hot spots, and then the emollient over the top. And families might be doing that twice a day. They might be kind of topping up a bit more during the day when they see things are dry. And then sort of the next level of treatment would be including the therapeutic baths in there as well. So I guess, a lot of like medical approach to that now is bleach baths. I don't know if you've come across that in your practice. It's a very common prescription, which I'm like, okay, let's try this herbal bath instead.
Because it would kill the staph.
Yeah, exactly. We want to eradicate staph is what the bleach bath is about. Right. And it looks, it's short term. It does seem to like bring things under control. So, and I think the other thing about atopic dermatitis is we have to be pragmatic. We can't be too like, dogmatic in our naturopathic principles. We've got to make sure that baby's okay, and that family's okay, and that this, they're not suffering, and they're not getting at risk of, their skin's so inflamed that they're at risk of ending up in, ER with an IV antibiotics because they got a secondary infection. So as practitioners, we have to be, moderate in just working with each individual, I think, and make, I guess we're working to need those things, hopefully less or not at all, but it's really working with what's needed at the time to kind of,
And I just want to list out some like people when they think about supporting the gut microbiome, they might like think probiotics or fermented foods, but I just want to make sure people know that prebiotics, and to ask you what you think, but to feed the gut bacteria with really good fibers like leeks and garlic and onions and burdock and like fiber rich plant foods likely is the way to go.
Absolutely. Yeah. Which is often not the diet that mothers have ended up on if they've gone on down to their 5 food foods. So, for the infant who's, if they're exclusively breastfed or predominantly breastfed, they've got all that in the milk, like it's loaded with prebiotics, and it's got, also beneficial microbes in there as well. So we're not needing to treat that infant directly. And most of the research on giving probiotics for eczema actually shows that it's most useful if you are going to give a probiotic to give it through the mum. So we don't need to we don't really know what we're doing when we throw a probiotic into that evolving ecosystem. Like, is it, potentially going to like change the trajectory of that evolution? I think there's just too many questions like in a situation where an infant's already kind of receiving all of that from mum. My approach is to work through mums, and yes, absolutely, for supporting mums' microbiome, like thinking about a plant food rich diet full of lots of whole foods and fibers and beautiful brightly colored foods, and that's the number one. And then I would think of boosting that with prebiotic supplements as well, so fertilizer for the good microbes in that system. And then maybe you might add a probiotic, one that was had some good evidence for mum to take on top.
Oh, that's such good information. Oh man.
Totally.
And what I love so much, that this is so much more, I guess, liberating for the mom, because when you're told that you have to go on an elimination diet because something you're doing is harming your baby and making them sick, it affects your mental health so much because you're concerned about them, and it takes away when you're eating, you're like, are they reacting to this, like after I breastfeed them, and it gets really intense. And so thinking about something like, your baby's crawling on a rug and they got a little rash, and then it got worse and worse, and then it turned into eczema. It's like, that is because of their skin barrier. It's not it's not your fault.
Yeah,
Like,
absolutely.
you're a good parent. And I think you see a lot, people kind of start spiraling when they start those elimination diets to see if it can help their baby. And this
absolutely.
it's such a different path to go this way
with it. And I think that just reminds me of this phenomena which happens to all of us as just human beings, and particularly parents, as we look for patterns. And so it's really easy when we're in a vigilant state for us to trying to look for cause and effect with our behavior, and be like, oh, I ate tomato, and then I ate tomato on Wednesday, and then Friday it's so angry, it's got to be the tomato. But we know how many, like, there's just so much noise in terms of the possibilities of what can be aggravating things. There's so many things, and just, I guess, trying to kind of take a step back and have a kind of a broader view of all the possibilities, and go, okay, like tomatoes one possibility, but also there's this, and this, and just to try and
Okay, do you have time, Dawn, before we go, to speak to what a non-breastfeeding
mom? Yes.
If you do have time. If you don't, we can...
Sure. So I guess it's worth initially just kind of thinking about, just to frame this, to think about the World Health Organization's recommendations on like the safest milk to feed a baby. So, the safest milk for a baby is mother's own milk directly from her breast. Then we get all that, all the kind of real-time effects, and we're not separating that sort of feedback that's happening there. There's a lot of like time-specific substances transmitted in breast milk, so that this is like, and we're not worrying about how it's stored or anything like that. The second, or what it's stored in, the second safest is mum's own express breast milk. The third safest is donor milk from, a safe and trusted source. So I think that's like something that, is often a surprise to people when I tell them that that's actually the World Health Organization's recommendation. That is the third safest thing. And then the fourth safest is formula made to, to guidelines. And then when we go, like the next would be like a non-modified mammalian milk, which is, becoming pretty unsafe by the time we get down there. Like, that's actually quite dangerous. So, and sometimes I think, families can be like, oh my goodness, I don't want to give my baby formula, and they can sort of think that making some sort of homemade option might be like a safer option, but this actually has like quite extraordinary risks associated with it. And you look like you've got something to say, Hannah.
I just I'm thinking, because that's so true, that people say not, you can't do those top options. Breast milk is not an option for whatever reason. You don't donor milk, but formula is terrible. I'm going to make my own baby formula from goat milk, cow milk. I think the
coconut oil in there.
Influencer recommends avocado.
Bit of chicken liver.
Blend it all up and give it to the baby, and that's much better. And it's interesting to hear that it actually is dangerous from a medical profession,
extremely dangerous.
It's like a natural user bias or fallacy, thinking that
it
just
is.
because
which I mean, I totally understand what drives that, and like, I think if you're talking about an older, like a young child or that's a different story. But when we're talking about an infant with their very specific needs and their vulnerabilities in terms of what their kidneys can handle, and it's just and the amount of things have to be really titrated well, and it's quite easy for their kidneys to get strained because there's excess solutes, or it's so that really, not that we don't want that option, but it's understandable that people consider that because of what you said. So I do think it's worth exploring donor milk options first, and particularly, the younger the baby, I think the more important it is to really try and see what donor options are available. And there are some papers kind of looking at, the considerations when you're assessing donor milk in terms of its safety and what sort of things should be checked. And you might be someone really well, and so you can be like, okay, have you had you had an HIV test, just things like that. There's just kind of actually very like the chance of transmission of anything through breast milk is extremely rare, but you just want to do these safety checks. So that resource, I can send it to you so you can put it.
That would be great. We'll put it in the show notes.
If we're in a situation where we don't have that as an option, I guess the other thing that other kind of value I have is that we don't focus too much on trying to find like the most ideal formula. We just think more about, is there anything we can do to support mum, and if there's like some breastfeeding's better than no breastfeeding, like just kind of making sure we're putting adequate energy into making sure there's good support there. And because I think sometimes that there can be a real distraction in trying to find the best formula option. And if we are down to the point that a formula is needed, then a mammalian milk-based formula rather than a soy plant-based formula. At this stage, we just know more about them in terms of their safety profile. And then, I mean, in that situation, I do think about, okay, what else could we do to support that infant microbiome in that situation? A lot of formulas are adding in prebiotics to them, so I guess it's a real, you want to see what's in there. There's so much marketing leverage around this because, basically the formula industry is always marketing their product against breast milk. So they're always trying to their marketing messages are pretty crafty. So just being really kind of aware of that, labels will have the labeling, like the laws are so loose, and, Australia and America haven't signed the WHO code around how we market breast milk substitutes. So it's, there's, it's an area to be careful of. But I do think about, potentially adding a well-researched prebiotic into that picture, but that is something you have to be pretty careful about in terms of choosing the right one and the amount. And sometimes I'll include a probiotic, but that's really a very, it's unusual that we find ourselves in that situation. We often kind of hopefully are in a situation where we might be able to explore a donor milk option, or more importantly, able to just really see if there's anything we can do to support that breastfeeding situation. Sometimes it'll just be like I've got to go back to work, or I need some formula because I've got to go back to work, and you're like, okay, well, let's just break this down a bit because there's there's ways of kind of exploring this in the way that you don't actually need to bring formula into the picture. So I guess understanding why that family is thinking that they need to bring that in. Not sure if I answered your question. I'm cautious because it's a cautious kind of area to talk about, I guess.
It is and I see what you mean, because every situation is so different for moms, and I think the going back to work is a big factor for so many women. And even though in the US where we are, and I'm guessing it's same in Australia, you are supposed to be able to pump at work, you're supposed to have a private space, you're supposed to have that time. I think that a lot of employers abuse that and don't really provide that for women, and the women don't realize that is their right and don't have the resources to make any efforts legally or otherwise, or seek other employment. And so it's kind of it's a lot for them to balance. And then you're probably also dealing with being separated from your baby because you have to go back to work, and the stress of that, and then just the pressure of having to stop whatever you're doing and pump. And then a lot of women hate pumping.
Oh, yeah.
It's awful. Like,
Yeah.
it's awful.
Yeah. And it's so inefficient. You're like, why am I taking this milk out to then, like
move it and all this,
and then I've like now my breast's empty, my baby's hungry, and like, or I don't know, it's just so like it's very inefficient.
There's a fun fact about the LaFont agency is that most of our videos were filmed in Andrew's employer's breast pumping room that they provide for because it's like the most beautiful room. And I was like, would you all let me use this room to film some videos? And they were like, totally. Like, if there's somebody in there, go for it. And I was like, yes.
That's that's so nice to hear. I mean, one thing I try and talk to families about is whether it's possible for the baby, either mum to drop in on the baby during the day at a care situation, or for the baby to be brought to them, even if it's just once in that period, can just really like be a game changer. And I think I think you're like, people are going back to work so early in the US, aren't they? There's a lot of pressure to go back to work. You don't have, like in Australia we have 16 weeks paid parental leave for mothers, so, and that's not enough. It's really not enough. I mean, it sounds amazing because you do a crap situation in your country, but it should be 12 months really if we're investing in. That doesn't mean that mums have to not work or like stay at home, but it just to be able to have that support so that you can just step into work as it suits you rather than being forced into it when your baby's so little. It's actually
5 weeks here.
5 weeks.
5 weeks of unpaid leave.
Unpaid. So we have 16 weeks paid parental leave that the government pays. I mean, it's just at minimum wage, but it's like, I mean,
it's a joke. That's for a vaginal birth. For a C-section, it's 8 weeks, and then you go
very
back.
Generous.
I know, right? It's 3 weeks, really. It's everything.
Oh my goodness.
And there's no paternal leave. I think different companies, some have different rules.
Yeah, it kind of shifts back onto the private sector, doesn't it? Yeah.
It's very problematic. I mean, really, it's all at that level of like the policy. The whole system is just really flawed, at least in our country. I mean, other countries have incredible prenatal and postnatal benefits. Like,
I mean, you can just see, like, as an individual mum, what you're up against when those are the policies that you have around you. You're just not. It's just not supporting breastfeeding. It really isn't. Like,
And Dawn, I just wanted to say, I think it's wonderful that you're being careful around this topic that has a lot of nuance that is mandatory for it to be useful. Like, it's something that I wish there was more of. We've memeified medicine in so many ways, and it's like the reality is like there is a lot of nuance and specific, and it's not a strategy, right? It's like I think sometimes people are so used to being marketed to or sold to that they're like, oh, people are withholding information, or I mean, I know Hannah and I have come up against this where we're like, it depends. That's kind of the answer for so many questions. And it's not that you're trying to be glib. It's because it really depends on the situation. So, it's like what you've covered where it's like, eczema can have all of these different reasons why it shows up. What we really need is this experimentation. And so I just want to say, like, I appreciate that. And to like say that to our listeners, like, this isn't a ploy. This is like actually how the body works. And you're like a responsible clinician for speaking about it in that way. And that's rare.
Yeah, thank you. Yeah, I think it's important. And I guess, we can understand how you can kind of make a specific, like a suggestion that can just get generalized in a way that's not helpful, huh? Like it's,
all the time.
Yeah.
That happens.
Yeah.
So.
Can I ask you one quick question before we go?
Sure.
Would you be comfortable sharing your baby's first food, solid foods?
Sure.
Do you remember?
Yeah, I have 3 babies.
Oh wow.
But they're all big now. They're not really babies anymore. But I mean, maybe it's just do we have time for me to tell a quick story about the one that I did the food exclusions with, who's the middle daughter? Because her father has peanut anaphylaxis. So I was like, oh my goodness, no way am I I want to do everything I can. She's like 21. So at that time it was like, you should exclude, like the message was, if to reduce allergies in the offspring, start from 6 months pregnant and go to for the whole time that you're breastfeeding, excluding all the common allergens.
So the opposite.
Opposite to what we understand now. Like we've done a full thing. So yeah. So I did that. And she's just one case study, but she doesn't have peanut anaphylaxis, but she has a lot of allergies. She's allergic to like guinea pigs, horses, cats, every pollen you can think of. I mean, who knows? You never know. But but her first food was apple. Yeah. Actually, and my youngest first food was apple as well. And sorry, my oldest first food was apple. And then the very youngest, her first food was like bitter lettuce in the garden that she just kind of, had gone to seed and she just grabbed it and I was like, all right, that's your first food then. It's like it's a choking hazard and a very interesting first flavor, but that's what it is. Yeah. What about you, Hannah? What was yours?
I think it was either a mashed fruit or a mashed avocado.
Yeah.
And my son, he wasn't excited about food at all.
Yeah.
Had no interest, which I was so disappointed about because I love food so much. And he just wanted the boob. Like that's all he cared about was nursing. And he didn't really eat that many solids until he was nearly 1.
Yeah. Yeah.
And I was very common about that for a while because people are like, he has to be eating solids. He has to be eating. But he was very robust. Like he gained weight. Like he was very well fed. So
you're looking at him and you're like, you don't look malnourished. I mean, it's amazing, isn't it? Like you grow them with your body only to 6 months, these big plump babies. And then there's this loss of faith in your milk as a food after that point, even though it's the most nutritious food in their diet. It's really interesting how that, if you can't see it going in, then don't count it. Yeah.
Awesome. Well, Dawn, thank you so much. This is amazing. Again, I know I said this at the beginning, which is when it needed to be said, but I'm not a mom, and this is still personally useful for me and fascinating, and just from a societal perspective. It's like I have dear friends that are moms that I'm absolutely going to share this episode with. So we so appreciate your time and expertise and attention to detail.
Thank you so much.
Yeah, it's been really, I love your questions. I just love, it's been so insightful talking to you both. And I think, I guess one thing I think we can all, just speaking to that concept of not being a mum, I think we can all be, I guess, that potential link for someone where we help to link them with good information. Like if the more informed all of us are about things relating to, breastfeeding or other health issues, means that we could potentially be that kind of link and that opportunity to link someone with some better information, hopefully.
Absolutely. Yeah, absolutely.
Which is what you're doing, isn't it? That's your mission, which is amazing. It's just so needed. My goodness.
Sometimes I'm like, are we moving the needle at all? But
oh, you are.
We're trying. We're having fun at least.
Oh, it's very exciting. Yeah.
Okay, thank you, Dawn.
Thanks.
Yeah, thank you so much, Dawn. See ya.
It's been great.